And Doug, you're going to lead us through this session, is that right?
Yes, and if I can ask the clinical practice guidelines, both military and civilian sector groups or people to move to the front. As they're making their way to their seats, I will just review the objectives for this session that were developed by the group, and I want to thank Dr. Redberg for assisting with those. To provide the committee with information on how guidelines are created and maintained, including the process for collecting and reviewing evidence, identifying potential conflicts of interest in authors, best practices in guideline formation, considerations for successful guideline development groups, and principal guideline writing for end-user usage. Also, to provide the committee with information on how guidelines are implemented, including methods of disseminating new guidelines, methods of communicating information about new guidelines, education for end users, and financial considerations related to implementation or reimbursement related to the recommendations in the guidelines. And lastly, for information on how guidelines are continuously improved, including methods for feedback from end users, consideration of evolving evidence, and method for regular review and updating of guidelines. On the military sector panel, we have Captain Stoltz Stockinger. He's the Director of Performance Improvement for the Joint Trauma System, U.S. Department of Defense. Also, Captain Retired Frank Butler, the Chair of the Committee on Tactical Combat Casualty Care, Director of Pre-Hospital Trauma Care, Joint Trauma System, U.S. Department of Defense. On the civilian sector panel, we have Carolyn Clancy, Chief Medical Officer, U.S. Department of Veterans Affairs, and Susan Kirsch, National Director, Clinical Practice Management for Clinical Operations and Access, U.S. Department of Health Affairs. And I don't know if you both went to the front. Only one of you is going to speak, I understand, correct? Or at least in the opening remarks, and that will be Carolyn. We're going to give her a little bit of Susan Kirsch's time, so she'll have 10 minutes. And Peter Talick, the Clinical Professor, Division of Emergency Medicine, University of Utah School of Medicine, also Medical Director, Bureau of EMS and Preparedness, Utah Department of Health, and a Colonel in the Medical Corps, State Surgeon, Utah Army National Guard. And Dr. David Calloway, co-author, Committee on Tactical Emergency Care, Casualty Care, Associate Professor of Emergency Medicine at Carolinas Medical Center. So we'll just go down the panel in the order that we have you listed, and Captain Stockinger, you're first.
Okay. Good afternoon. Committee members, just so you know, I'm Jolt Stockinger. I'm a Navy trauma surgeon who came to the Joint Trauma System about 1.5 years ago. It's my honor and privilege to be able to speak to you today regarding the Joint Trauma Systems process for the development, promulgation, and updating of clinical practice guidelines. Before I go into my remarks, though, I would like to make some personal remarks. There's a committee member missing today. That is Dr. Norman McSwain, who all of you know is a legend in trauma care and trauma system development, especially in the pre-hospital arena. Norman was my mentor during my trauma surgery fellowship at his beloved charity hospital. In fact, I was his last trauma fellow before Katrina came through and changed the landscape a little bit. And so I'd like to ask that Norman be in your thoughts and prayers as he is in mine over the coming few days, and that you think of him and his family, because obviously he cannot be here today. America began its involvement in Iraq and Afghanistan with a very robust military medical capability, but it did not have any overarching oversight to the quality of trauma care that was being provided by those military healthcare providers who went down into the deployed setting into an environment that they were usually very unfamiliar with. In essence, a unified trauma system such as exists in many American communities, which has coordination, communications, and sometimes process improvement across the spectrum of care, was by and large lacking from this. Now, I have to say it's not really surprising that it was lacking when you bear in mind that, unlike the relatively static system in the United States, the military elements that make up the military trauma system and their personnel are mobile. They're very flexible. They often change. They can move at a moment's notice. And that system spans thousands and thousands of miles with multiple handoffs of each patient to move that wounded warrior from the battlefield back to his or her home. So it should also not be surprising that patient care that was being provided by deployed healthcare providers was significantly variable, given that the majority of those healthcare providers normally did not practice trauma care and were usually very inexperienced in both trauma care delivery at their normal working place inside a hospital and trauma care delivery in the deployed setting. And if there's one thing we all know about deployments, is every deployment is the same because they're all different. Confounding this was the fact that we had a less than robust ability to actually collect trauma patient data in an austere and under-resourced environment, as was discussed by the previous panel. Well, in 2004, through the urging of people like then Colonel Douglas Robb and Colonel John Holcomb, the Office of the Deputy Assistant Secretary of Defense for Health Affairs mandated the establishment of a trauma system within U.S. Central Command, within a well-defined geographic area that did not span the entire Defense Department, the entire military system. The data depository for this was established by Dr. Holcomb and by Ms. Spott, who just finished speaking to you, within the U.S. Army Institute for Surgical Research, and even before the formal initial establishment of the U.S. Central Command Joint Theater Trauma System. And I have to distinguish that the Joint Theater Trauma System was the team of medical personnel deployed downrange to Iraq and Afghanistan to abstract data and provide performance improvement. It's distinct from the Joint Trauma System as currently exists in San Antonio, which includes the data repository and was the U.S. permanent support piece for the constantly deploying and rotating teams. However, even before the first CENTCOM JTTS team went downrange in 2005, by December of 2004, the U.S. Army Institute of Surgical Research, under Dr. Holcomb's leadership, had already created 8 clinical practice guidelines based primarily on subject matter expert opinion for what were perceived as significant problems with care downrange, including inconsistency in how patients were being resuscitated, or damage control resuscitation, in the management and prophylaxis for deep venous thrombosis and for vascular trauma. Since that time, the number of CPGs has grown to 43, and as you can see here, the number's been going up every year. We even have a CPG on how we make CPGs. Imagine that. We are the government, after all. The average revision timeline, as you can see, compares extremely favorably with that seen in civilian systems. When I go to the next slide, you will see that this is the process that we have in place for the actual development of those CPGs. The first thing you'll notice, or the second thing you'll notice actually in Block 2, is that these CPGs were developed specifically for U.S. Central Command, so they were not developed to be DoD-wide process. When they were developed, and they could be recommended by anybody, these CPGs were then vetted by the deployed Joint Theater Trauma System director, who was located physically in Iraq or Afghanistan, vetted by them through the medical personnel actually deployed in theater at that time to ensure that those CPGs were relevant and achievable. And then they were approved by the U.S. Central Command surgeon, who's the senior medical advisor to the commanding general for U.S. CENTCOM. With the drawdown of personnel in Afghanistan, however, the last JTTS team in theater, which I happen to have led, departed theater in December 2014 without replacement. So all the performance improvement processes that had been occurring physically downrange are now being done remotely from San Antonio. And we did plan to do it that way, so there was a significant forethought put into how those processes were going to be done remotely. But as you can imagine, it's not quite as straightforward as being able to walk up to someone and ask them a question about a patient that was just treated. Well, with the formal transition of Operation Enduring Freedom into Operation Freedom Sentinel on January 1st of this year, the San Antonio-based JTS has decided to shift away from CENTCOM-specific clinical practice guidelines. And so we will be updating guidelines no longer specific to any geographic combatant command. We're referring to these as vanilla clinical practice guidelines. So the steps you see in this slide that are outlined in red will no longer be used in our CPG process. Basically, they'll no longer be vetted through CENTCOM Joint Theater Trauma System because we don't have those deployed personnel and we don't want these to be CENTCOM specific. Each CPG will continue to have SME representation from all U.S. services. and in many cases from civilian SMEs and also from allied military subject matter experts. And we're actually currently in the process of revising and reevaluating every single CPG we have, with the intention that they will be completed by the end of this calendar year and posted on the JTS website, which is an open source website that is available to anyone, not just to the U.S. military. Once these CPGs are completed, they will be distributed to the senior medical leadership of each geographic combatant command for their review. If they choose to approve them as they stand, they are we're more than happy to have them do that. If they want them modified to their specific geographic location, we will assist them in that because we are the joint trauma system, and so it's our job to do that. We'll be ready to assist any COCOM or military organization that wants to modify them or to create new ones as they see fit. And with that, I'd like to thank you for your time, and I'll look forward to answering your questions a little bit later on.
Thank you. And I'll just announce, I think that most of the panel saw the previous operations, but when I put my name tag up vertically, you have about 2 minutes remaining. And I'm told I was authorized to turn Dr. Marcosi loose to strong arm anybody that goes past their time.
Not
Captain
Dr.
Butler.
Marcosi, yeah. Yeah, thanks for the chance to be here today and for the honor of speaking to this Institute of Medicine panel. I'd like to start also by saying how much Norm McSwain helped with everything that we're about to talk about, and how much I wish he were here today to see this presentation. Do say a prayer. So, if you go back to the start of the war, 2001, here is what our military was doing for battlefield trauma care. And for those of you who are civilians, if this looks pretty much like what was happening in the civilian sector at that time, it is exactly what was happening in the civilian sector. So we didn't have any combat-specific trauma courses. We taught our medics never to use tourniquets. They had no hemostatic agents. They had no junctional tourniquets. If someone was in shock, we taught them to start IVs and give them large volumes of crystalloid fluid. We started 2 large bores IVs on everybody who was significantly injured, whether they needed it or not, because they might need it. Our analgesia was provided by Civil War vintage technology, IM morphine. We had no focus on prevention of trauma-related coagulopathy. There was no tactical context for the care rendered. The courses literally taught these guys to be doing secondary surveys and starting IVs while bullets were pinging off the rocks around them. Contemplate that for a second. There was a heavy emphasis on endotracheal intubation for pre-hospital airway management. And that was where we were in 2001. So flash back to 1993, there was a biomedical research project undertaken initially by Naval Special Warfare, the Navy SEAL Command, which then was transitioned to the U.S. Special Operations Command. And this research project was carried out with tremendous help from the Uniformed Services University of the Health Sciences. So great partnership. This project made a few executive decisions at the start. The first was we were going to focus very closely on the major causes of preventable death on the battlefield: hemorrhage, airway obstruction, and tension pneumothorax. Our thinking was, and the fact is, that if we can get our casualties to the hospital alive, then Captain Stockinger, Colonel Eastridge, Dr. Holcomb, Dr. Beakley in the back, our trauma surgeons will do a magnificent job of taking care of them, but only if we get them to the hospital alive. So we're in combat. The care, the strategies used by the corpsmen had to reflect good medicine and good tactics. It doesn't do any good to treat your patient well and get everybody in your unit killed while you take the time to do that. Things like prolonged evacuation times had to be considered. In the civilian sector, we're spoiled maybe with 15 to 20 minute times to be transported to the hospital. In the military, at the start of Desert Storm, that time was 4 hours. In Afghanistan, when I got there in 2003, it was longer than that. It's much faster than that in Afghanistan now, but we've been there a long time, and the theater is pretty mature. We had extensive combat medic input to the guidelines. You would never ask somebody who's going to be expected to use these guidelines to use them without input as to what they say. And then lastly, and maybe most importantly, the rule of evidence was applied not just to new interventions, but to existing recommendations. Example, you have a corpsman who's treating a Marine Corps casualty who is in the process of bleeding to death from a femoral artery. Okay, so what is the evidence for using tourniquets to save this person's life in 2001? I will tell you, there wasn't much. Flip that over. What was the evidence for not using tourniquets and letting the casualty bleed to death, which they would do very quickly from that kind of an injury, even less. So the rule of evidence was applied to both the existing standard and the new standards that were being entertained. So a brief history of how it went from there. The paper was published in Military Medicine in 1996. It was slow to transition. By the time the war had started, and bear in mind that was 5 years, the only people using it were the Navy SEALs, the 75th Ranger Regiment, the Air Force PJs, and the Army Special Missions Unit, and a few very scattered other units. So the vast majority of the U.S. military was not using it. By the end of the war, everybody in the military was using it. And I will give credit for that fact to the Committee on Tactical Combat Casualty Care, and it's pretty amazing to consider that in this room, as we sit, there are 8 current or past members of the committee. There are 10 more people who have been personally involved with the TC3 committee's effort, and you know what? It's not that big a room. That's 18 people, so we've had tremendous help. Mrs. Embry, when we were founded by Navy Medicine and operating out of there, helped me to understand that I was in violation of federal law and moved us to the Defense Health Board, where we operated very well for 5 years. And I'm still not in jail, thank you. Admiral Smith and General Robb have certainly helped now that they are general leaders, but they helped immensely before they became famous and had a great personal investment in TC3 and earlier in their careers. So, and on and on. Dr. Jacobs now is helping with the Hartford Consensus to make this information available to the civilian sector. Dr. Callaway and Dr. Smith will tell you about the Committee for Tactical Emergency Casualty Care. So it's been a terrific, coordinated, combined effort. So, if you look across the U.S. military now, battlefield trauma care is pretty much completely different. Compare this slide later to the previous slide. There's almost no overlap. So we have phases of care now in tactical combat casualty care. As the gunfight winds down, the medical care ramps up. We aggressively use tourniquets and care under fire. We use combat gauze as a hemostatic agent. We teach junior corpsmen and medics to aggressively put needles in chest if the situation calls for it. We try not to intubate people if the casualty is having airway problems. It's usually because they are shot in the face. And the best way to manage that, if the casualty can do it, is just to sit up and lean forward and spit it all out. And we have used that with tremendous success during the war. If that doesn't work, then we go directly to a surgical airway. We now understand about controlled resuscitation, controlled volume resuscitation. We start IVs only when we absolutely need them. We have a completely different approach to battlefield analgesia that incorporates fentanyl lozenges, PO medications, and ketamine. We understand about preventing hypothermia. We understand about not taking a half pound of Motrin before you go out on the battlefield. We would like for your platelets to be working if you get shot. We understand about battlefield antibiotics. Read Bob Mabry's paper from Mogadishu, where they had a 15-hour delay to evacuation and had a 30% infection rate. We use TXA, and we have junctional tourniquets. It's a whole new ballgame out there. So, that all sounds good. You guys are the Institute of Medicine. Your next question is, okay, so what? Well, here's a so what. So we've gone from the wilderness to near complete acceptance in the DOD in 14 years of war. And if you've ever worked in the DOD, you will understand the magnitude of that statement. The DOD, people think that an executive can issue an order and everything changes. That's true, but there's only one executive who can do that, and he hasn't done it yet. There has been a 67% reduction in deaths from extremity hemorrhage. That is a remarkable reduction in our leading cause of preventable death. If you read Mike Tarpey's paper from 2005, he was the first person to publish. His words were overwhelming success in the drive to Baghdad. John Craig's research enabled him to estimate to the U.S. Army Surgeon General that over 1,000 lives had been saved with tourniquet use, and that was 2008. So I'm reaching in my pocket for the tourniquet. This is a $25 device. And after Colonel Holcomb at the ISR helped us to understand that this was the best tourniquet out there, and yes, it did stop you from bleeding to death with 100% reliability, we've turned pre-hospital trauma care around with that device. So Russ Coatwall, the Ranger paper, and in a military that has the highest casualty survival rate in history, we still have a 24% preventable death rate. The Rangers, starting the war with TC3, had a 3% preventable death rate. Pretty remarkable reduction. The Canadians have published a paper which has a little bit less granularity but the same result. Our best casualty survival in history, and we're now working with the American College of Surgeons, the National Association of EMTs, and trying to preserve our gains that we've made both in the military and transition some of those to the civilian sector. So that's all I have. Thank you again for the privilege.
Thank you, Captain. Dr. Clancy.
Thank you and good afternoon, everyone. I'm very personally delighted to be here this afternoon, first because much of what we do serving veterans, of course, has a great deal to do with how well they are cared for in the Department of Defense and their service injuries and so forth, and also because I think the work and the dramatic successes achieved in trauma care was really the frontier of rapid learning and what many are now glorifying and, talking about in very, very lofty terms as a learning healthcare system, but they made it real. So kudos just seems like a very mild statement, but I felt the need to say it. What I want to talk about is a program at VA that we run jointly with our colleagues from the Department of Defense on clinical practice guidelines. Although, to be fair, having had a long career at the Agency for Healthcare Research and Quality, where I think we first got into the business of clinical practice guidelines in 1990, some insights or reflections from that experience may creep in. I want to talk about our processes. I want to talk a little bit about engaging or involving patients in the process of clinical guideline development, and then talk about how do we move these into practice and implementation. And frankly, how do we get back to this rapid learning piece of incorporating evidence in a fully electronic world? That is the promise of electronic records, right? I mean, simply digitizing what we've been doing on paper is not really something that people get up very excited about every day. The notion that we could be smarter because we can effectively farm or grow new evidence rather than constantly be hunting for it, I think is what makes people very, very excited. And I think of that as the interface of performance improvement and evidence development that was coming up at the end of the last discussion. So we have an evidence-based practice work group, and the focus is on evidence-based practice guidelines. So this is a standing panel. We don't have a separate panel for every single topic. We do roughly 4 to 5 of these a year, and this comes out of a joint health executive committee between Veterans Affairs and the Department of Defense. And this is not for all of practice, right? So the focus here is on conditions that are more prevalent in service members and veterans, or that have unique manifestations or unique implications for service members and veterans. We are not reinventing the American Diabetes Guidelines and so forth. And in terms of how those topics are identified, there is a process by which almost anyone can identify particular topics. And that 4 to 5 a year also includes updates, which we try to do on a 5-year cycle. And I will just note that we have been highly influenced and grateful for the report from the Institute of Medicine on guidelines that you can trust that came out several years ago. So this is a standing panel from which work group members and chairs are drawn, and each of those must disclose potential conflicts of interest on a quarterly basis. As I discussed, there is a process for requesting guidelines, and there's a very clear charter with implementation tools. I should also note the fact that we draw heavily on and are delighted to do so from guidelines developed by other professional organizations does not mean that we don't have our own internal policies, which frankly I think would benefit from some of this discipline. And I'm happy to tell you that they will be doing just that. I don't mean to actually startle my colleagues into thinking that their jobs have just tripled or quadrupled, but having earned the dubious distinction of being selected to be on the GAO's high-risk list, we will be taking a very close look at all of our policies, which were described as ambiguous, which is fair. I meant to acknowledge my colleague, Dr. Susan Kirsch, who is a leading proponent on the guideline panels, and Dr. Eric Rogers, who's sitting right behind Don Berwick, who actually leads all of this work. We also work very closely with the Guidelines International Network, and all of these guidelines are preceded by a systematic review, which I think was a pretty strong recommendation from the Institute of Medicine report several years ago. And we use the grade system for grading the quality and strength of the evidence. We are at all times, probably more informally than we should be, looking upstream to imagine what might be changing the picture for the topic at hand. So for example, pain management is going to have a lot to do with how JTS directs analgesia in the battlefield. We have worked a lot with colleagues in the Department of Defense in learning battlefield acupuncture techniques because of the shared concern that both Defense and Veterans Affairs have for getting into opioid issues downstream. If that pain can be managed effectively without opioids from the outset, or at least postponed, you can imagine that that puts everyone in much better shape subsequently. The issue of how do you engage patients and families is one that I find completely fascinating. And some of this gets to the whole issue of who is a representative voice. On one level, patients, individuals affected by the disease or condition under discussion makes perfect sense. On the other hand, they may have extremely strong opinions and be a bit less neutral about the value of evidence, regardless of which system one uses to evaluate the quality of that evidence. I can tell you that I love science, but the depth and passion that our colleagues bring to their usually 2-day meetings, sometimes 3, is a bit much even for me. I'm not sure that, I think it would be an acquired taste for many patients and family members. So at what points in the process it makes the most sense to involve that perspective is something that we're still working through, as far as I can tell, are most professional organizations who struggle with this issue. I know in the Guidelines International Network there is a robust discussion about whether we should be training standing panels of consumers and patients who might be able to participate in discussion of any topic, which I find pretty interesting. And probably the best example I can think of is the National Breast Cancer Coalition's Project Lead training, where they actually train people to become pretty adroit peer reviewers of research applications, and have moved that same technique on to engage their people in assessing quality of care. We're using patients most commonly in a mostly ad hoc fashion and in helping them evaluate implementation materials, usually through focus groups, because about a third of the people who work for Veterans Affairs are veterans themselves. So they tend to be a very handy sample, but we're looking forward to pushing that frontier. So presuming that we have followed the Institute of Medicine recommended practices, the question is then, so what? What is the impact of this guideline on practice? And we're still at the phase of exploring a great deal of opportunities for improving that impact, from webinars and other didactic sessions to actually using simulation. And if there's one area that I think is missing from clinical practice guideline development, at least in a systematic way, it's actually incorporating human factors and workflow, right? If you give people expert advice which is not remotely implementable, that's something interesting to read, but is unlikely to have a big impact on practice. How we get these to the point of care is something that we struggle with a great deal. I would have to say right now, if I were to poll leading clinicians at VA, I bet that they would all be voting on apps. Right? An app is something very specific you can get your hands on and actually look at how you're doing for a particular patient or a patient panel and so forth, without getting cluttered by everything else. And I would submit that that's going to be the next frontier or big challenge as all of us become where electronic work in systems where electronic records are the norm, rather than the big brave new world that we're really looking forward to next year, please, not right now. And the question is, can we use other kinds of modalities? How else do we socialize the use and uptake of new evidence into practice? And I think that that is something that we share with the Department of Defense and so forth. I came in on the tail end of the last discussion. One big game changer in an increasingly electronic healthcare world is the creation of registries from an electronic record platform. Please notice how the words just rolled right off my tongue. This has actually been something that's trickier than you might think for our health system for many years, because although we say we have an electronic record system, right now today we have about 128 different versions of our electronic record, but we are now in the full throes of developing a new open source platform, which we're calling the Electronic Health Management Platform, which I think will make this a whole lot easier. Because after all, no matter how superb the trauma care looks, fantastic to reduce mortality, the question is, what kind of life do you have once you transition out of service and are being cared for at the Veterans Administration or in the civilian sector or whatever. And quite honestly, as we buy more care in the community, which is going to be very much part of our future, figuring out how to do this with civilian colleagues who will be seeing some of our veterans for some portion of their care, I think is also going to be part of the challenge. So I know there are probably some of you in the room who mourn that we don't have a single electronic record for defense and VA, and I don't think we need to open that sad story from the past again. But I will say that interoperability becomes even more important for both departments as we have to increasingly interact with colleagues in the community. So with that, I am going to stop and pause here. Would look forward to your questions. Again, I think the real question here is, or the big challenge that I have is, the frame for developing clinical practice guidelines is preceded by a systematic review of the evidence, and our traditional path to doing that is through the peer-reviewed literature. The question is, in an increasingly electronic world where we can get evidence about what has happened to these people, how do we incorporate that information more rapidly? Brent James and I had a very robust and lively conversation with Susan the other day about perhaps we're being a little too fussy on the front end and over-developing when what we ought to be developing are good guidelines that we expect that we will refine over time as we look at the impact on practice right now and develop much more of an iterative cycle rather than a once every 5 years in the absence of some breaking new evidence process that we have right now. So thank you for the opportunity.
Thank you, Dr. Clancy. Dr. Talick.
Hi, thank you very much. Dr. Butler, be kind enough to pass the PowerPoint baton this way, please.
Thanks.
Thank you very much. Again, it's an honor to be here and be asked to speak to the committee. Thank you very much. Let's see if this works. There we go. So, unlike most of the august members I'm presenting with, no one here knows who I am, and so I'm going to give just a quick overview of that, if I may. I'm an emergency physician. I work at the University of Utah. I practice medicine and get to teach residents, which is one of the 2 highest privileges of my professional career. The 4th bullet there, as a military physician for 25 years, will speak to the highest privilege I've had in my medical career, is taking care of soldiers and our volunteer heroes on the battlefield in Iraq and Afghanistan. I think I'm here because I've had some experience at both the state level as well as participating in multiple national level projects to develop evidence-based guidelines for pre-hospital care and to study and make efforts at their implementation at levels extending from national to state to individual agencies. I was privileged to be invited to be part of the ACS Hemorrhage Control Guideline Development Panel. Very proud of that product. I loved it because it was incredibly simple, and incredible simplicity goes very well in pre-hospital care. It was heavily based, as everyone here knows, on the military literature, and thanks to the members in this room who have made all that possible. The guideline was interesting in that we utilized the grade process, and despite best efforts, the military and pre-hospital care community has trouble doing randomized controlled trials in the field. The battlefield is much really like the pre-hospital care field, where it's very much uncontrolled. Someone's living room is a different size from the next living room that the ambulance providers go into, and there's 2 sets of stairs in one building and 6 in the other, making comparative trials difficult. So I really appreciate the effort involved in collecting data and the magnificent product that the Joint Trauma Registry is for providing this. Interestingly, I learned a lot about the grade process during the American College of Surgeons guideline development meetings. And I'd like to point out that though the military studies were rated as low quality for multiple reasons, they're retrospective, many of them even though prospective, but not randomized. Because of the preponderance of evidence for tourniquet use, the evidence was upgraded to moderate because each of the studies available pointed in the same direction of definite lives saved on the battlefield. This has revolutionized hemorrhage control in the pre-hospital care environment. And I've had the benefit as a Utah State EMS medical director to help operationalize some of that in our state of Utah. Let me point out some of the limitations, if I may, of this. The translation of military to civilian is often difficult because the studies are done in a completely different environment. Care under fire, short of SWAT teams and disaster events for routine EMS doesn't exist. I just rode along with my paramedics just a couple of days ago and noticed that there was 6 providers at the scene of every 1 patient. And it's pretty much the opposite in the military experience. 1 provider is taking care of 6 patients very often at the scene of an IED in the field. So again, how translatable is this evidence? I would submit that it's a lot easier with 6 providers to hold pressure on a wound. And I'm a giant tourniquet fan, don't get me wrong. But when you got 6 people standing around with nothing to do and 1 patient, 1 guy can hold pressure on the wound while someone else prepares the pressure dressing, you might not need a tourniquet in that case. So I think we have to be a little careful about the tourniquet to be careful here, bandwagon, if you will, swinging too far in the other direction, away from the simplest methods of hemorrhage control, particularly directed at populations of untrained civilians, of simply putting pressure on a wound and calling for help, because it's often quickly available in the civilian environment. Let's see. Did I go two? Okay. I've been privileged, as several people in this room were as well, to be part of the National Association of State EMS Officials Model EMS Clinical Guidelines Project. And this was a project based on the 2007 IOM report, Emergency Medical Services at the Crossroads, that recommended that we develop evidence-based guidelines for pre-hospital care and promulgate those. Thanks to our colleagues at NHTSA over there, Drew and Kathy and your team for supporting this effort. Multiple organizations were involved, including American College of Emergency Physicians, American College of Surgeons, Committee on Trauma, NAEMSP, pediatrics, cardiology folks got around the table and looked at evidence-based guidelines where available for pre-hospital care, and then developed consensus-based guidelines where those were not available. This document was published 11 of last year, so November of 2014. It is available on the web at nasemso.org, and I encourage you to take a look at it. It's a really pretty piece of work, if I do say so, for us. It incorporates performance improvement measures for each of the guidelines, which I think is currently an untapped resource and a goal for all of us to decide when we put out these CPGs or EBGs that we incorporate ways to look at them after they're utilized to see, are they actually doing what we hoped they would do. Challenges for this project include the dissemination. Currently it sits on a website. There have been several EMS level presentations done to introduce them to the EMS community, and little by little we've had some good feedback that they are being looked at and currently adopted or modified by agencies for their own private use, which is their design. Not to be used as a whole, although you're welcome to, but to be looked at and modified according to local standards and local conditions to hopefully standardize the level or the quality of pre-hospital care. Quickly, another implementation-related project with which I've been involved as one of the co-PIs is to take the recently published pain guideline, evidence-based guideline by Dr. Gaucher Hill and her team, and to operationalize, disseminate, and implement that in 5 states with 5 different state structures, EMS operative structures. Some states have voluntary pre-hospital guidelines that are published. Some states have no voluntary pre-hospital guidelines. So to help state EMS offices find the best ways to disseminate this guideline throughout their EMS community down to the ground level, and to look for the barriers to that implementation, document those, and see how we can develop best practices in the future to further disseminate evidence-based guidelines as they're available for our pre-hospital care providers. One of our challenges in this, beyond the bureaucracy at each state that varies, as you can imagine, is number one, defining what is success in each state, because all the states we picked have a statewide emergency patient care system registry. But what is success? Is success the number of doses of fentanyl given out? Is success the number of medics who take the training? And so we're looking at all of these to see how do we measure the success of the implementation process in each state. Let's see. In Utah, I've had a little success, and I think it may be relevant of interest to the panel in a couple of projects. One is we put together our own statewide model guidelines prior to the NASEMSO project. And we made these voluntary, and this is one of the take-home points I had, is when you put together a set of quality, evidence, or expert consensus-based guidelines and incorporate all the right people i.e. the folks who actually do the work, the medics on the panel, the medical directors, the pediatricians, et cetera, all those who are involved, and put out that product and just let people know it's there. If you build it, they will come. We've had very good success with these voluntary guidelines. If many, if not most, of all of the largest EMS agencies in the state adopting them and then modifying them to some extent to meet their personal needs. Likewise, we put out a new clinical practice guideline recommendation about hypotensive resuscitation in trauma patients, which has been widely accepted as well, and again is voluntary. So my lessons learned, my last slide, Doug. Evidence-based guidelines, in my opinion, are pretty easy to sell. If you provide good quality, if you don't shove them down physicians' throats, particularly EMS medical directors, who can be a rather independent lot, I might add. And if you show them that there's good data and good science, most of them appreciate the work because it keeps them from having to do the laundry and the medical legal concerns about having their own pre-hospital guidelines and updating them on a regular basis, et cetera. Military guidelines certainly need some sort of translation. Keep in mind that we're not on the battlefield. However, the concepts and precepts that are developed on the battlefield certainly have applicability. We need to incorporate outcomes measures, as I mentioned before, to make sure these guidelines are doing the work that we want them to do. And then lastly, I've learned in my job, you can't change too much too fast at the pre-hospital care level. There are hundreds of thousands of paramedics and tens of thousands of EMS agencies around the country. And if you give them too much too fast, it becomes very confusing for them. They don't know what to do next. Thank you very much for your time.
Thank you, Peter. Next is Dr. Callaway, and I apologize. Probably most of us in this row can't see you, David, but if you can't see my marker, Peter can give you.
That's okay. I talk fast and
Peter
I talk
can
loud.
pass on a 2-minute warning.
And Mark Cozy will probably throw something at me if I go too long. So my name is Dave Callaway. It's an honor to be here, especially in front of so many friends and mentors. And I too am saddened by the lack of a good friend and mentor, Norm McSwain. So we obviously we hope him well. I was a 10-year member of the Committee on Tactical Combat Casualty Care. I was a Green Lieutenant just back from Iraq when I looked to try to find some better way of training my guys. And I emailed SOCOM Surgeon Captain Butler. I had no idea what SOCOM was. I'd been in the military for 6 months. And he brought me promptly onto the Committee on Tactical Combat Casualty Care. I sat there for 10 years and then joined the Defense Health Board Trauma and Injury Subcommittee and then helped co-found the Committee on Tactical Emergency Casualty Care. In 2003 to 2005, I trained over 3,500 Marine sailors and Special Operations personnel in TCCC. Captain Butler then came to me again and said, "Good work, Dave. Now bring it to the civilian setting." And I think he said this to a lot of people, but as a young guy, I took this as a personal challenge. And over the next 5 years, I trained over 100 different law enforcement, EMS, and fire agencies in what was a modified TCCC. Universally, what this experience showed me were three things. I'd like to just use these three to set the stage for what we're going to talk about. Number one, TCCC and COTC, the Committee on Tactical Combat Casualty Care, despite the debates about the data, I do believe has been critical in decreasing our combat mortality to one of the lowest levels in recorded history. Number two, TCCC only works when it is applied as a system. And this has been proven by Dr. Eastridge's study, which shows 24% potentially preventable mortality, compared to Russ Cotwall's study that showed the Rangers have a 0% pre-hospital potentially preventable mortality rate. And the reason is it was applied as a system for the Rangers, and DoD-wide as a whole, it's been a somewhat more ad hoc application. And then number three, the successful translation of combat lessons learned to the civilian setting requires a commitment to the principles of high reliability organizations, or HRO, and that TCCC serves as a tremendous foundation and model, but cannot simply be transposed into the civilian setting. So we talked about the history. I was not the only one doing this. There are probably dozens or hundreds of people between 2005 and 2011 working on cracking this nut. In 2011, the Committee on Tactical Emergency Casualty Care was stood up as a 501c3 nonprofit with a mission of being a best practice development group for the provision of trauma care in the high-threat pre-hospital environment. Now, high threat doesn't just mean active shooter, doesn't just mean terrorism, doesn't just mean IED. It means anywhere where you have restricted access. So it could be a fire, it could be a building collapse, it could be a mass casualty. There are different tactics that are critical to be implemented into the trauma care. And as TCCC showed us, tactics and trauma care cannot be separated when you're talking about the pre-hospital environment. The structure of the committee is modeled after the COTC, and we took 3 core lessons. One is the guidelines themselves. TCCC started with Bellamy's data in Vietnam and then proved what was valid and what was not. We started with the TCCC data and did the same thing. So the data that Captain Butler ended, the slide that he ended with, which was look at where we are now, that was our starting point, not the 2001 data. The committee composition of making sure that the medic has the same vote as the trauma surgeon, that was critical for us. Our committee is a multidisciplinary committee that has multiple people who are just law enforcement officers, who are ALS, BLS, critical care, emergency medicine, trauma surgeons, pure PhD academicians, and then policy people. And each one has a vote, and it's equally weighted. It's a 24-person voting committee. We then have a very robust board of advisors, which include people like Captain Butler, Dr. Holcomb, Dr. Scalia, people who are legends in the field who are really the people who can help guide whether we are on the right track or not. And then this tie to the TCCC committee with founding plank holder members of the TCCC committee ensure that we have the proper process, the proper lessons learned from the military are being pushed in the civilian setting. So why not just use the TCCC guidelines? I tried. Man, that would have been easy. I mean, 3,500 people trained. If I could have just used the same thing and gone out and trained everybody, it would have been great. But the problem is that there's a different mission, there's a different operational environment. So in combat, the mission is to clear, hold, kill. And in the civilian setting, pre-hospital, even if you're talking about a high threat environment, the mission is inherently a rescue mission. It is about the victim. If there's an active shooter event, the reason the cops shoot the bad guy is to stop them from killing more people. It's not to go take land that the bad guy is holding to take the land. It's to prevent them from killing more kids, school teachers, or people at a movie theater. So in addition, there's a different risk tolerance, there's a different liability environment, the patient population is different, Coumadin, peds, geriatrics. We need to take that into account when we talk about how are we going to translate these guidelines and how are we going to get the important components to be highlighted and the specific details to not block this implementation. And I'll tell you, the fact that one of the key lines in TCCC is the best medicine on the battlefield is fire superiority. And if you talk to anybody in combat, that makes absolute sense. And if you talk to anybody in the civilian setting, it's a non-starter for any chief of any agency. Especially when we talk about the militarization of the police force, there is nobody who can sign off on that and then answer a Reuters interviewer who says, wow, you've got 50 cals, you've got armed vehicles, and you're teaching your medics to be combatants? That's interesting. So the problem is that barrier blocks the important part of what the guidelines are saying. So our guiding principles, high reliability organization, I'm sure many of you are familiar with this, but I'd just like to talk about it briefly because this is how we run the committee, and this is, I think, what has been a key to our success. So preoccupation with failure, reluctance to simplify, sensitivity to operations, commitment to resilience, and deference to expertise. So the reluctance to simplify is the key of why we can't just take a military system and put it on the civilian setting. There are different wounding patterns, different populations. Bob Mabry is one of the guys who has always harped on who owns battlefield medicine, and it's hard to answer that in the military. Who owns civilian pre-hospital medicine? I mean, we had this question earlier. Is it NASEMSO? Is it FICOMS? Is it it's the state medical director or the local medical director? So the players are even more complex, so you need to be sensitive to that. You can't mandate that a fire chief who bought $50,000 worth of Celox gauze now has to use combat gauze. Because if you do, they won't implement the guidelines because it's a fiduciary challenge to implementation. And what you really want them to do is use a hemostatic as part of a comprehensive hemorrhage control program. But they will turn you off unless you are sensitive to their operations. So commitment to resilience, I think this is one of our key strengths as well. We have multiple working groups within the committee that talk about the first care provider. So we heard a little bit about this earlier, but the first care provider was a concept published in 2011 about how do we take bystanders and make them active responders. The first care provider is the non-professional first responder on the ground. They are the first link in the chain of survival, followed by the non-medical professional first responders, so the law enforcement, and then followed by ALS and BLS. Process for rollout. Two key points here. The Institute of Medicine has a standards for developing trustworthy practice management guidelines. It is in some of the reading that you all have, but it basically says establish a transparent process, conflict of interest is managed, et cetera. There are 8 or 9 different points, all of which are met by the CTEC. The process is completely transparent. The guidelines are published, multidisciplinary input. And then when we talk about what is the challenge with pure translation, again, if you use the PICO method, you get stuck on P, right? Because the military has a population or patient base, which is generally 18 to 40-year-old, in general, males, in general, that they are providing trauma care for. The civilian population is different. So as we push to develop additional evidence that supports what we're saying, we need to take that difference into account. And this is just for the record on our QI and PI process. I'm happy to talk about that a little bit more. But as my time's running short, I want to stay within this. So why are we succeeding? Right mission, right team, right process, right partners. Our mission is to build resilience and reduce potentially preventable mortality in the civilian setting. The team is multidisciplinary. It represents everybody who touches a patient, whether it's law enforcement, emergency medicine physician, a first receiving facility, so the 50% of hospitals that see trauma that aren't trauma centers, and then it's right partners. We have representation, either direct liaisons or participation from NASEMSO, ACEP, American College of Surgeons Committee on Trauma, the Interagency Board, et cetera, et cetera. So is this working? As of July 23rd, we have 100,000 first responders and physicians trained nationally in TECC. The American College of Surgeons evidence-based guidelines for hemorrhage control that came out in 2014 support the guidelines and endorse, basically they're exactly consistent, so they provide a level of evidence to what has been recommended. The Hartford Consensus document also lends the weight of the American College of Surgeons to these guidelines that have been pushed out by the Committee on Tactical Emergency Casualty Care since 2011. And if you look at the American College of Surgeons or American College of Emergency Physicians First Responder Grant, it's based on TECC. The FBI's prime partner for active shooter response, the ALERT program in Texas, is based on these guidelines. And FEMA has committed almost $2 million in the last 4 years to rolling out tactical emergency casualty care training across the nation. So I think that this is a tactical dive. I know we've been talking strategy, but this is I think an example of a successful translation and implementation on a $15,000 a year budget. So I'm happy to take any questions during the Q&A session. Thank you.
Thank you. Let's see where we are on time. We started, I'll say what everybody, all the other panel leaders said, we started 10 minutes late. Hopefully we'll try to end maybe 5 minutes late beyond our time. I know there's a break coming up after this. Dr. James, did you have that up for a question? Questions from the Committee on Guideline Development, Implementation, Operations, Education, Dissemination, etc. Dr. Burbick.
David, if I could ask you to talk a minute more, could you, just so we've heard it once, if I was a new arrival ready to be trained by you in, say, TCCC for starters, or TECC, whatever you want, what happens to me? Walk me through in 2 minutes what the education is.
So it's distinct. So I still train special operations medical personnel in TCCC. And so if it's okay, I mean, NAMT has a TCCC curriculum that is endorsed, and the military has some of their own special modifications. On the civilian setting, what the Committee on Tactical Emergency Casualty Care has done as a best practice development group has said, we have offered the what and the why, and we leave it up to the local medical director to develop the how. And I think that that's very important, because we heard from NASEMSO representation earlier today that this needs to be a local solution. And what we found is some people like to do a one-day refresher training that focuses on the concepts for their medical director. Some people want to do high-fidelity simulation. Some people want to do guns and big drills. It's not our job to tell them how to train it. We offer support in the guidelines of what we think should be trained. And then we also offer to connect people with successful models of training. So FEMA has funded technical assistance programs, which are 2-day events where the leadership will go to a city and they will actually help a fire and EMS or a law enforcement agency stand up a city or municipality-based training program. We also have academic programs like Johns Hopkins that just trains it to their people through their academic organization. There are private sector people that train this as well. And what we do is serve as both providers of information and then also connectors of people who are doing the training. So is that, or do you want me to be granular more? So if you're are you a medic, a cop, or who are you?
Make me, well,
Besides,
pick one. I don't get a sense. Is it one day I'm going to spend with you, 2 days, or 2 weeks? Am I being full immersion? Is there a refresher course? I want to get just a tiny bit more.
right, so we don't do that. So we are not a training organization. We put out guidelines. NAMT has developed a TECC course, and it's a 2 or 3 day course, and it's the NAEMT TECC. We are an open source guidelines development group. So you can go get on the web, pull our guidelines, and say, I'm going to create a training. If you want to know how to do it, you can call Dr. Smith, Josh Shapiro, who's got a $1.3 million FEMA grant, or myself, and say, I'd like some help, and we can provide you with slide decks. We can provide you with training, past performance, and people who we think do good training. The way we do it, though, is there's overlapping training because this has to be trained as a system. So we will train you based on your background in what is your role in the trauma chain of survival, and then we will also train to the left and to the right. So if you are a law enforcement officer, we come in and we meet with your chief and we say, and the medical director for your city, and we say, what do you want your guys to be able to do? And then we say, well, okay, Roger, we think that all of that's good. Or we say, hey, have you thought about this? And once we figure out what they want to do, what their resources are, what their mode of operation, their medical direction is, then we figure out a way to create this concept of how you create a chain of survival that implement these policies. So integrating the first care provider, the law enforcement, non-medical, and the ALS, BLS providers.
If I could, I'd like to respond to that as well. We've learned over the years that it is absolutely critical that you have a common base of knowledge. And General Miller is helping us. We are currently, because of some bad outcomes, when we go back and look at things that happened that should not have happened, often it was a question of somebody being taught the wrong thing and told that it was TC3. So we are now trying to evolve more towards a standardized course, a 2-day course where we know exactly what's going to be taught, and we try to minimize what we call instructor drift. And then on top of that, you as the organizational person can add whatever additional things that you would like. If you want to do field exercises, if you want to do advanced computer simulation, if you want to do more airway practice, if you want to do live tissue training, knock yourself out. But you get a standard 2-day course, and we hope that that will reduce the incidence of training-related bad outcomes.
And Dr. Burke, if I may just add one, so the committee has approved what's called a recognized training content agreement. And so people who want to train and use the logo of the committee sign an ethical use statement, sort of like being a Mary Kay cosmetic salesperson, that says we agree to abide by the principles that you have laid out in the committee. And then we have basically students that audit it. We have local representatives who basically give us feedback. But because we are not a federal, state, government agency, we have no regulatory authority to go in and say, you can't do X, Y, or Z. What we can say is you're not compliant with the guidelines, you can't use the logo, and you can't call it TECC. But that's how we maintain some of the QI on the training.
So just to make a brief comment, I think the question you asked is very interesting in this whole conversation. First of all, the Mary Kay analogy will stay with me for a while. So thank you for that. Yes, I did bring a pink folder. But it does strike me that this interface between what and how is pretty critical and vital to this translation to the civilian sector. I mean, you've got much more control in the military and know exactly who's out there, which is not to say you can control the circumstances by any stretch of the imagination, but I think in the civilian sector, the issue of, or the non-battlefield sector might be an easier way to say it, that how piece is really, really vital. And I think one of the weaknesses of our medical enterprise is that we've assumed if it was up here, that execution was just like gravity, except it turns out not to be.
John.
So, Dr. Clancy, a question that relates a little bit to the previous panel, which you weren't on, and I recognize that, but now you're here and you're representing the VA, and so I'm going to take advantage of that. And it does relate to guidelines and evidence basis for guidelines. And I'm going to speak specifically to trauma guidelines, because that's what we're here about, and the interaction between the VA and the Department of Defense. and registries, which you did talk about. So you all have registries. The DoD has a registry. They don't talk to each other. So in the DoD registry, there's no outcome data, rehab data, long-term data. So how can the DoD write a good guideline in an evidence-based fashion without the VA data? Can you help me through that a little bit?
Well, what I heard in the discussion, the part of the discussion I was here for, was that there's an enormous opportunity, and I'd be delighted to follow up with you on that. We right now, for the past several years, have been building a corporate data warehouse. Now, the initial phases of this, as you might imagine, were on top of all of the other little localized, very idiosyncratic data storage points. We're now getting to the point of establishing some robust governance for that, and ultimately, dare I say this out loud, we'll probably be, graduating, ending some of the more local efforts. Because if there's one thing we've learned in the past year since our crisis, is the utter essential aspect of being able to be sure of fidelity of data, what we see at central office, what is seen at the network, what is seen on the ground. And I can say for access to care and wait times, I think we're pretty much there. We're going to have to learn how to explain that in English better, but that's a different story. But I think for many other aspects, particularly what are the medium and longer term outcomes from trauma, this feels like a really important opportunity.
Can I just, you guys should really talk about this with Captain Stockinger and yourself and whoever else. I mean, it's an extraordinarily important effort. I will tell you that in 2003 and 4, I mean, this has been going on since 03, 04, trying to make this link happen, and you articulated it very clearly and have an opportunity results maybe to make it happen finally. It'd be great.
Philip. Yeah, my question for the panel, and anybody who's willing to answer it, please do so, is how can we prevent conflict of interest from seeping into our clinical practice guidelines? As you can imagine, the research investigators are often our subject matter experts, and they're the ones that go ahead and write the CPGs. And you can see where there could be a potential conflict of interest there. So what is currently being done to prevent that? And if it isn't being done, what can be done in the future to reduce that risk?
So Phil, if I may, I'll take that. This comes up for TC3 all the time because we do recommend specific products, and we do that because all trauma care products are not created equal, and we don't want our soldiers, sailors, airmen, and Marines to be treated with 99-cent tourniquets. Gee, does that sound like that could never happen? It happened. So when Colonel Holcomb and his researchers at the ISR put out a report that says, hey, here are the tourniquets that work. We recommend that you use tourniquets that work. So we looked at that. We took a second look at it. At the time, Dr. Holcomb did not have any commercial interest in the tourniquets. Somebody did, for sure. And we thought that the data were convincing, and we endorsed them. I will tell you that for every product, it's different. We do invite subject matter experts to come and talk to our group. When they're there, they have to disclose that they have a financial interest, and we record that in our deliberations. But, if we're looking at a new device, it makes sense to have the person who knows the most about that device there, and we often will. But, we think that if you are going to practice evidence-based pre-hospital care, then you have to follow the evidence. You can't accept brand neutrality as your guiding principle. It's evidence-based, and that means just what it says.
So if I could address this from the civilian side, because as we were standing up and as a member of COTC, having dealt with these issues when I was on the committee, the issue obviously becomes a little more delicate in the civilian setting and a little more complex, and this goes back to the HRR principle of sensitivity to operations. The way we have handled that is by taking a brand neutrality approach on our formal recommendations. Use a tourniquet that has these qualities. But then when we provide links to the data, we provide links to, if the data is all about the combat application tourniquet and the soft T tourniquet, we allow our end users to interpret that data and make a decision. And this goes back to respecting the local medical director's decision to either make a good or bad decision based on the data. So we recommend a tourniquet, we recommend a hemostatic dressing, and then we provide the links to the data on, here's combat gauze, here's Kytoflex, here's Celox. We invite industry to come, and we usually, when we have industry come to a meeting, we'll pick a topic, so it'll be hemostatic dressings, and we call it the Battle Royale, and we have a representative from each of the relevant industries, and they're able to present head-to-head with each of them in the room, declared conflicts of interest, and then in our open meetings, much like this forum, anybody, whether you're a member of the committee or not, can ask questions, pose recommendations, and pose concerns.
If I could make one more comment, just briefly. First, we would be happy to leave the committee with a copy of our policy on how we handle this. There's a strong focus on transparency and disclosure. And I'll say that what I learned from my prior life at ARC is that although it's clear that transparency and disclosure are necessary but not sufficient, because oftentimes when people have disclosed, they feel like they're fine and that's the end of it, specificity is incredibly vital. Because the bottom line is, if you ask any breathing human, are you conflicted? The usual answer is no. It's when you ask questions like, have you ever worked for a company? And, have you worked for that company? And have you been reimbursed for work you did for them in this particular area? Sometimes that initial no becomes quite more nuanced.
On the military side, for the CPGs outside of the pre-hospital CPGs, we actually really haven't had much of a problem with this. The pre-hospital, the TCCC guidelines, are addressing technologies and products that are being created as we speak to fill gaps that currently exist. And so it's not surprising that new products pop up all the time that people want the TCCC committee to recommend, because it's a new product and we think it's just as good as the products that you've already recommended. The majority of the CPGs that the JTS has, though, are a little bit different. We typically don't recommend specific products, partly because we don't know which products are going to be available wherever those folks deploy. Because the CPGs are designed to be used outside of a hospital environment, in a tent or in a dirt or in a field. And if you've ever been to some of those places, while a field hospital may be a field hospital, every service's field hospital is different and has different equipment and different resources. So we try to keep our recommendations for products very, very generic. We may say second generation cephalosporin, and then that way whoever's reading the CPG looks in whatever pharmacopoeia they have and they pick whatever they have to work with. But for the majority of the JTS CPGs, it hasn't been a problem because we just stay away from brand names in general, mostly because it never really comes up.
I'm going to add one more comment to what I said before. I'd emphasize that the Committee on TC3, if there is not evidence to support recommending a particular product, then we make a generic recommendation. And good examples are eye shields. There's no recommendation for that. Nasopharyngeal airways, there's no recommendation. So where there is not evidence, there is not a recommendation. The second thing, when you say tourniquet, the extra caveat that you have to throw in there is, and seared in my memory, is the picture of the Special Forces soldier who died with 3 tourniquets on. He bled to death from his popliteal artery. Colonel Holcomb sent me the picture, and I showed it to General Brown. And you said, well, he's got tourniquets on. How could he die? Well, because they were improvised tourniquets, and they were improvised poorly, and they didn't work. So when you say tourniquet, you have to caveat that.
Could you pass the tourniquet around to the committee that you had with you?
And we'll go Dr. James, Hayter, and then Marcosi.
I want to shift to a slightly different direction. My own personal familiarity with this really dates to the late 1990s when evidence-based best practice guidelines started to be widely used. There was actually quite a body of research, and I was collecting it at the time. What it showed is that the model of preparing a guideline, training the clinical team in it as your primary deployment model, that if you asked the physicians and the nurses, they would say it was a very, very valuable activity. That if you asked them if they'd changed their practice, they would say that they had. But when you measured whether they changed their practice. The changes were small or non-existent. Is there a new body of evidence around that? Do we have good success stories about deployment? What's your thoughts about that? You're in this field. Are you able to demonstrate that it does produce changes in practice? If so, at what rate? What are the methods by which it rolls forth?
So this is the absolute beauty of the Joint Trauma System process. If you are a Marine Corps corpsman in Afghanistan and you take care of a casualty on Tuesday, and he has a gunshot wound to his leg and he bleeds to death, the entire world knows about it on Thursday, and there is a feedback mechanism that goes back to your unit now. It's typically informal. We're not looking to be judicial about this, but we don't want our guys to bleed to death, and if you let that happen as a corpsman, then you have some retraining to do. So we have a very rapid feedback mechanism with the Worldwide Trauma Conference.
So you're enforcing it top down. What do you propose for a civilian system?
One of the things that came out of the Hartford consensus discussions was that there's absolutely no counterpart to that in the civilian sector. As Dr. Callaway mentioned, there are legalities, there are lawyers involved, there are political groups involved, but I think that if you can correctly extrapolate from events, I mean, imagine if Mike Ferguson had bled to death from a popliteal artery wound in Missouri. You know, we know the right things to do. We should do them.
The whole world would know. Do you mean the rumor mill would make it known, or you? So the Worldwide Trauma Conference every Thursday, at least when the war was in serious, when it was in full swing. On the average day, we would have 25 casualties. And we would go over all of the things that happened to each casualty, and in most cases, the care was appropriate and the casualties were covered quickly. If we got something like a person who bled to death from a gunshot wound to the thigh, that's a red flag. And we were able to break that out quickly and take remedial action. So it's not worldwide. That was a misnomer, except that, I mean, geographically it's worldwide. There are probably 100 people on the call all over the U.S. Central Command, from some of the other combatant commands, from Washington, from San Antonio. So it was worldwide in geographic scope, but not in number.
And if I can tag on to that, since I am the Director for Performance Improvement for JTS, when these cases are presented, they are completely de-identified in terms of date, location, name, who the providers were, and so on. To number one, because it's not a true peer-reviewed morbidity and mortality conference. It's more a system-wide conference. So we look at individual problems that occur and address them at a systems level. Now, separate from that, if we identify a particular problem at a particular location, potentially with a particular group of providers, we as an organization will actually contact that location one-on-one, separate from the weekly conference, to discuss those particular issues with them, to try to educate them. Every one of our clinical practice guidelines has performance metrics built into it that we review when we receive that patient's chart. And by doing so, we're actually able to track compliance. We have not been able to do it successfully with every CPG we have, but just to give you an example, from a few years ago, it was identified that missed compartment syndrome was a significant problem in polytrauma patients with multiple extremity injuries. As they moved through that lengthy continuum of care, compartment syndromes were developing that were missed, that could have been prevented. So compartment syndrome CPG was developed, and after that CPG was put in place, oddly enough, the number of fasciotomies went way up, and the number of compartment syndromes went down to almost nothing. So we do track those particular metrics, and those metrics are built into each particular CPG. So our performance improvement nurses at JTS will review each chart for those specific metrics, as well as any additional adverse events.
I have a civilian version that I think is relevant, that is a best practice. You said, Dr. Butler, that there's no civilian version of the Thursday conferences, which I loved in my little base on the border of Pakistan and Afghanistan, I might add. It was remarkable. But we have regionalized trauma systems developing in various states. And in these regionalized systems, there is often a series of spoke feeder hospitals into a hub central trauma center. And in the best examples, we have a county in Utah that's both urban and rural, where the level 2 trauma center is the leader, and there are 4 level 4 trauma centers that feed into them and share the trauma care with them. Monthly, they all meet and they review cases. The EMS providers are present, the ED folks are present, and the relevant trauma medical directors and trauma program directors are present. It's a remarkable opportunity for them to review cases, not every case, as is the case on the battlefield and was going on, but to review index cases and cases where lessons can be learned. So I think with these regionalized trauma systems, there's the opportunity to reproduce this.
And just on the civilian side, 2 sort of gaps and challenges. I mean, the awesomeness of the JTS is also, it's the horror in the civilian side. We don't have it. It's ad hoc data, especially when we're talking about these type of interventions. We don't, so just take the specific of active shooter incidents. Virginia Tech, Aurora, the Navy Yard, Sandy Hook. How did the people die? Does anybody know? Right, because so that's a problem. And it's because data gets locked away for legal purposes. They don't release how people die. We know the people who lived because we have academic people who write papers about it. Or we have such a diverse network that we've talked to people like Rich Kamen, who is on our committee, who is the doc on scene at Sandy Hook. So I know how the people died at Sandy Hook because he told me. But he can't publish this and he can't write about it. And so that gap is a significant problem when we talk about these interventions. We also don't have a near-miss database. So the FBI has the LEOCA database, the law enforcement officer killed in action. That tells you how officers died. It does not tell you one single thing about an officer that got shot in the leg and had somebody put a tourniquet on him and then, or her, and then they lived. So the near-miss database is a significant problem. The fact that there's no standardization. The way we've gotten around it is because in Charlotte, much like Houston, I think, Dr. Holcomb, we own everything. So we own law enforcement, BLS, ALS, and the trauma center. And so I know that all of my guys and every single piece of the pre-hospital care and the trauma center are on the same page. They know that they're getting feedback immediately. We collect data, we publish case reports, which aren't great science, but we publish case reports that show that this works. And as a result, what has happened is law enforcement agencies around the country have emailed us data on their interventions. Tucson, Greenville, several other cities, because they're not bound by HIPAA. I have entire lists of law enforcement interventions with names, with interventions, with injuries, but the second they get to a hospital, I don't know what happened to them because of HIPAA and because IRB requirements. And so, I mean, if we could figure out a way to crack that nut, whether it's the National Trauma Database or whatever, I mean, that would be hugely powerful.
And I'm going to ask that we have 3 more committee members that want to ask a question. If you could keep them to 1 minute answer, and maybe if there's a specific panel member that you want to direct it to.
I have 2 very quick questions. First is to Captain Butler. The Eastern Association for Surgery of Trauma, EAST, provides great clinical practice guidelines used by trauma surgeons. They made them available free of charge to all service personnel working overseas. Is there any discussion with the military to go back and forth with those EAST guidelines, or are the military making some and EAST is doing the same ones over and over?
Okay, as a member of EAST and a member of the military subcommittee for EAST, I'll certainly go ahead and answer that one. I'll answer by posing a question. Where do you think some of our guidelines started with? Some of our guidelines started with the relevant civilian guidelines from EAST or AAST or other organizations, SCCM for things like ventilator-associated pneumonia, and then we adapted them to make them applicable to a military non-hospital setting. So we've already gone ahead and done that. And the EAST military subcommittee works very actively with EAST as a group to maintain that military-civilian relationship. For example, EAST made available free of charge a large number of extremely important or landmark trauma papers that they could just look at free of charge on their website for folks who were downrange and couldn't get access to PubMed and all the usual sources. So we've already been doing that as part of the development for our guidelines, and I know the TCCC committee looks at all the relevant available guidelines also when they make their recommendations. Now, that said, there's a number of the guidelines, were developed de novo just because there was nothing out there.
On the heels of that, diffusion of TCCC guidelines, for example, to the civilian population, Dr. Butler and I, we've done this study together to show very poor diffusion for certain things like IOs and needle decompression. Any comments on the challenges there and what we can do to improve that?
That is a great point, and we have a paper coming out in the next issue of Journal of Trauma that Dr. Smith and Dr. Carmona and I did that discusses why it took the U.S. military as long as it did to change its therapies during the war, and how do we preserve that? It's a recurring theme that after every war we've really honed our trauma care skills, and during every peace interval those go away. And so how do we keep that from happening this time? And don't think they can't. So in understanding that part of it and working with Dr. Jacobs and trying to understand the difference between the civilian sector and the military sector, you have the same problem. It's different, but it's the same in that nobody's in charge. Every state has its own director. Every trauma center has its own director, and that's a lot of people to convince. We have spoken with the chief medical officer at CMS to discuss the fact that if a doctor can be dinged for not using a computer to make their medical record, why aren't they dinged for letting a patient bleed to death? So that point has been raised. It has not been acted on, but I do think that there has to be a will, and there has to be somebody willing to figure out the organizational politics to make it happen.
David, short question. Short questions for Captain Butler or Captain Stockinger. One wish in 5 years to improve the CPG. What does it look like? And give us that wish. And the TCCC guidelines.
Just one, Marco? Just one, Marco?
Just one, sir.
For the Secretary of Defense to take it as a personal action item, just as Secretary Gates did in 2009 with the evacuation time. That produced dramatic results, which are just now being documented. If the Secretary of Defense said, these are the recommendations from the Joint Trauma System, and not just TC3, but the Joint Trauma System CPGs, and the recommendations that have been carefully crafted over 14 years of war, and said, this is our roadmap for success. I want everybody in my department to make this happen. That's a big one, but I think that's what it's going to take to institutionalize the success that we've had in taking care of our casualties from Iraq and Afghanistan.
Okay, and just to add to that, for the CPGs themselves, while it's not a perfect process, it's very robust and seems to be working very well. So my wish for the CPGs would be 5 years from now that every U.S. geographic combatant command be required, not suggested, not recommended, not it would be a good idea now, not we'll think about it, but be required by the SecDef to have a skeleton COCOM trauma system in place with an identified trauma system director, who is a trauma surgeon, and program manager and pre-hospital director, because all three of those are critical, and that the TCCC guidelines and the clinical practice guidelines, whether JTS or COCOM specific, be considered to be the standard of care within that COCOM.
Ellen, last word, last question.
Could you repeat those three roles, the three roles that you just said?
The three things. So each COCOM be required to have a skeleton joint theater trauma system essentially designed for their geographic area. That they have the person now identified to run that, which would be a trauma surgeon, a nurse, a program manager, and a pre-hospital director. Because as we know, each of those things in isolation doesn't work, and that the TCCC guidelines and the clinical practice guidelines, whether JTS vanilla or COCOM specific, be stated to be the expected standard of care within the geographic area. And I'd also like a pony for Christmas.
My question is for Captain Butler and Captain Stockinger. The evolution of clinical practice guidelines in a trauma environment is pretty rapid compared to other clinical settings. And I have a specific question having to do with off-label use of devices and drugs and how you process that. I had a few challenges in my career around that topic, and I want to know how the system has evolved to address that more thoroughly.
For me, I have a rather glib answer to that. I inherited a group of clinical practice guidelines that have an exact disclaimer about the off-label use of drugs and devices built into every single one. Now, that said, it is a glib answer, and it's my understanding that a lot of the regulatory aspects of devices and drugs within the continental United States, from the FDA's perspective, are essentially irrelevant once you leave the United States. So we have this sort of loophole, but it's not necessarily a very good loophole. So that's why, in general, we tend to shy away from naming specific drugs and devices.
So for TC3, we look at FDA approval as necessary but not sufficient. However, an FDA indication is not necessarily required, and I'll give you two great examples. Fentanyl lozenges, which are the combat medic's best friend if you want to relieve your teammates' pain without having to stop and start an IV. They are not indicated for use on the battlefield. We use them anyway. TXA, we have the best evidence for anything that we do in TC3 for TXA improving survival and trauma. Love the data, hate the data. We talk about it all the time. It is the only level A evidence that we have, and guess what? It's not indicated for use in trauma, so we use it anyway.
Well, I guess that the reason I asked the question is because if we're talking about clinical practice guidelines, guidelines are one thing, a word of mouth about what works and what doesn't is another. And I think I would never want to limit the communication between practicing physicians. But if we're trying to translate this to civilian practice in the United States, we need to think about the proper method to address this that is outside of a clinical practice guideline.
Yes, ma'am. For more and more civilian trauma systems are now using TXA, and it is just as off-label for them as it is for us.
Well, I'll defer that to Don, who has to manage the time of the committee.
Yeah, we're already over almost our entire break, so maybe at this point we could thank the panel. This is an amazing panel. Thank you for your time and energy. I really, really enjoyed it. I'm sure there are going to be follow-up questions here, by the way. We have one more panel left before the public comment period at 6. Bill, you're in charge of that panel. I'm going to try to give us a break. We didn't have one, so could we let's take a 10-minute break.
Okay, one other thing, whoever has my tourniquet.
Yeah. And please be back here in 10 minutes if you possibly can. Thank you so much.